Good morning, and welcome to our Quality Assurance Review Conference. The Quark Grand Rounds is an opportunity to review cases and topics that are related to quality and patient safety issues. Today we have the pleasure of hosting Dr. Beth Raucher, Yasmin Hernandez, Truong, and Ken McCardle for an update on sepsis. Dr. Raucher is the Vice Chair of Quality and Clinical Affairs. She's a graduate of the Mount Sinai School of Medicine, where she also completed her internal medicine residency and fellowship in clinical microbiology and public health. Subsequently, she trained in infectious diseases at the Albert Einstein College of Medicine. After completing fellowship, Dr. Raucher joined Beth Israel Medical Center, where she was Chief of Infection Control, Medical Director for Clinical Informatics, and Chief of the Division of Quality Improvement for the Department of Medicine. Dr. Raucher completed her Master's in Healthcare Management from the Harvard School of Public Health, and in 2006 became the Chief Medical Officer and Executive Vice President at Lutheran Medical Center in Brooklyn. Dr. Raucher returned to Mount Sinai School of Medicine in 2014 and worked closely with the quality champions at each of the hospitals to achieve the Mount Sinai Hospital and Department of Medicine quality goals. Dr. Yasmin Hernandez received her medical degree from Stony Brook University School of Medicine and completed her residency in internal medicine at the Icahn School of Medicine at Mount Sinai. She currently serves as Chief Resident for the Mount Sinai Medicine Residency Program and will be a gastroenterology fellow at the MGH in the fall. Dr. Truong is an Assistant Professor of Medicine in the Division of Hospital Medicine at the Icahn School of Medicine at Mount Sinai. She received her medical degree from Temple University and completed her internal medicine residency training at Yale New Haven Hospital. Dr. Truong is the chair of the DOM M&M Committee and is an active member of the Mount Sinai Sepsis Steering Committee. Ken McCardle is Senior Director, Clinical Operations for Mount Sinai Health System. His team serves as the centralized data management to build and maintain clinical data registries and patient cohort databases for surgical centers, clinical institutes, complex diseases, and clinical care pathways. Mr. McCardle is an active member of the Mount Sinai Hospital Sepsis Steering Committee. Please join me in welcoming Dr. Beth Raucher, Yasmin Hernandez, Truong, and Ken McCardle.
Good morning, everyone. So the objectives for today's talk, we're going to go through a few cases from the Department of Medicine and then define sepsis. We'll review the literature that supports the current standard of care for sepsis. We'll define what a care bundle is and how we apply that in the management of sepsis, understand our current data here at Mount Sinai Hospital, and also go over some of the future directions and goals. Does anyone know what these three men have in common? Right. Correct. Does anyone know from what infection? I think I heard all three. So Christopher Reeve, he passed away from a deep infected pressure ulcer. Pope John Paul II passed away from sepsis secondary to a urinary tract infection. And Jim Henson passed away of a beta hemolytic strep infection. So let's review a few of the cases. There will be an opportunity for about a minute of questions at the end of each case. The first patient is a 68-year-old female with a history of stroke. She was nonverbal and non-ambulatory at baseline and had a PEG tube for feeds. She was sent in from her nursing home with abdominal pain, increased moaning, and increased output from her PEG tube. So let's go over her case. When she presented to the emergency room, she was hypothermic to 35.7 and tachycardic to 114. Her initial labs demonstrated a lactate of 3.4 and a white blood cell count of 14.6. The emergency room gave her 1 liter of normal saline, which was about 16 cc's per kilogram, and they gave her a milligram of IV morphine and admitted her to medicine to evaluate for a possible abdominal obstruction or PEG tube malfunction. Her abdominal x-ray showed a likely ileus and no cultures were sent at this time. When the medicine team saw her at 8 hours after presentation, she was more hypotensive and tachycardic to 110. Cultures and lactate were sent at this time, and she received an additional liter of fluids. She was also started on vancomycin and cefepime because they were concerned for sepsis, and her urine culture was concerning for an infection, or her urinalysis. At 12 hours, she was more hypotensive and persistently tachycardic, and her repeat lactate had actually increased to 4.1 despite receiving the 2 liters of normal saline. She got an additional liter, and her blood cultures grew gram-negative bacilli at 9 hours, and they continued her antibiotics. At 20 hours after she presented, She was still hypotensive and her IV infiltrated. They wanted to give her additional fluids, but were unable to. After multiple providers and nurses attempted to get IV access, they were not able to, and a central line was placed by line service. At 34 hours after her presentation, she received 2 liters, which was 32 cc's per kilogram. She was brought into meropenem because of her infection history, and her blood pressure responded quickly to these IV fluids. The remainder of her hospital course was unremarkable. Her blood and urine culture ended up growing pan-sensitive E. coli, and she was narrowed to ceftriaxone, and she went back to her nursing home on hospital day 7. Any questions about this case?
So why weren't the cultures drawn when she was admitted?
I'm sorry?
Why weren't the cultures drawn when she was admitted? Because she had evidence of...
So correct. So she did have evidence of SIRS when she presented. She was hypothermic and tachycardic, and she had a leukocytosis. But at the time, in reviewing the documentation, they were concerned that she had a possible abdominal obstruction and did not think that she was infected. Any other questions? Okay. So the second case is of a 58-year-old male with a past medical history of pulmonary embolus. He was recently admitted for staph capitis infection that was complicated by Stevens-Johnson syndrome, toxic epidermal necrosis secondary to an antibiotic, and AKI, which resulted in end-stage renal disease and then required hemodialysis via perm cath. He represented to the emergency room with swelling and pain at his new AV fistula site and purulence from the perm cath site. When he presented to the emergency room, he was febrile to 38.5 and tachycardic to 100. The physician documentation when he first came in said they were concerned for sepsis secondary to a primary bloodstream infection, and the perm cath had tenderness, erythema, and purulent drainage. But antibiotics were not given because of an allergy to vancomycin, cefepime, and imipenem, and they would consult ID. IV fluids were not given because the patient was on hemodialysis and he was admitted to medicine. 10 hours after presentation, linezolid was ordered and administered after the ID team was consulted, and the ID documentation read that they would strongly encourage perm cath removal and administration of linezolid. 15 hours after he presented, he was still tachycardic to 116 and more hypotensive than he had first presented. He underwent dialysis, a scheduled dialysis session where they removed 1 liter of fluid, and he had this done through his perm cath, and the patient reported chills during dialysis. Around this time, his blood cultures grew gram-positive cocci in pairs and chains, and it later speciated to enterococcus. On the second day of hospitalization, the documentation read that they planned to remove the perm cath, but it was not removed because of patient stability and an elevated INR, and no fluids were given on this day. At 61 hours after he presented, he triggered the sepsis BPA for tachycardia, a blood pressure, a systolic blood pressure less than 90, and at this time he received 1 liter of normal saline, which for him was about 12.2 cc's per kilogram. And that amount was given because the patient is an end-stage renal disease patient and scheduled for dialysis tomorrow. 3 hours after the BPA triggered, he was reevaluated. He was persistently tachycardic and more hypotensive. His lactate was 2.1. At this point, the patient was somewhat altered, and he received 3 liters of normal saline, which was 36.6 cc's per kilogram, and his blood pressure rapidly improved after the 4th liter, and his vitals stabilized. On the following morning, the perm cath was promptly removed. His blood cultures cleared, and the patient was discharged off of antibiotics on hospital day number 10. Are there any questions about this case?
What was the thinking that was behind the delay in removing the perm cath?
So in reviewing the chart, the patient's blood pressure was still normal. It was still well above 110. There was concern that it was over the weekend and he was getting appropriate antibiotics. And his INR, because of his pulmonary embolus, he was on Coumadin, and his INR was quite elevated when he presented as well.
Did a nephrologist see the patient?
They did, and they also recommended removing the perm cap. So that's why we're here. To learn. Charlie?
I was wondering, did the nephrology team or the primary team communicate with the nephrology team about kind of the entire clinical scenario and whether they wanted fluid removed, or was that kind of just done by dialysis?
So usually he was a patient that did have problems with volume overload, but when on all the physical exams that were documented, he was on room air, lying down comfortably. So in this case, he didn't show evidence of volume overload.
Was his normal blood pressure 110? Well, I mean, when it was recorded, what was his actual normal pre-dialysis blood pressure?
His pre-dialysis blood pressure was about 120, 130, so he was pretty well controlled, so it wasn't a big change from his baseline. One last question? Okay, so let's take a moment and just briefly define sepsis. Sepsis is a severe inflammatory response to an infectious source that can result in multi-organ dysfunction and profound vasodilatation that can ultimately lead to hemodynamic collapse. It's very important to think of sepsis as a spectrum. It starts with SIRS. So SIRS is an inflammatory response that is marked by abnormalities of two vital signs or abnormal white blood cell count. Sepsis is SIRS with a presumed or confirmed source of infection. Severe sepsis is sepsis with the presence of end organ damage. And septic shock is a state of hypotension, which is refractory to fluid resuscitation, necessitating the use of pressors. And the reason why it's so important to think of sepsis as a spectrum is because the earlier on you intervene, you're going to have much better outcomes for your patients. I'm going to hand it over to Dr. Raucher to go over some of the data.
All right, good morning. So we're going to review some of the statistics surrounding sepsis and the literature. So sepsis has a huge impact on our country and our economy. 750,000 patients every year develop sepsis, and greater than 250,000 die of sepsis. That's over 35%. It accounts for 11% of all acute care discharges. The cost is over $25 billion a year, and it accounts for 40% of total ICU expenditures. It's a #1 killer in the state of New York. 22,000 patients, greater than 22,000 patients died in 2011. The numbers are a little bit higher now, although that was the last report I could find in the statistics on the New York State Department of Health website. But the cases are increasing, and I don't think so much because there's more sepsis now. I think it's because we're recognizing it now. We're doing a better job of early recognition of sepsis. It did go up 68%, but again, I think it's better recognition. Also, some good news is mortality is improving because of early recognition and management and all the attention that sepsis has gotten since the death of those 3 men in the first slide that Yasmin showed, especially Jim Henson, who died, I think, in one of the New York City hospitals here. Mount Sinai, we're very lucky that we are able to leverage EPIC and the best practice alert to have an early warning system. So we have a sepsis best practice alert, a BPA as everybody knows it, which will warn us when there's a change in clinical status of a patient. The RN, the nurse, bedside nurse, receives the BPA for a change in vital signs, will go to the bedside and assess the patient. If they corroborate that the patient has a change in status, they'll call the team, and during the day they'll call the sepsis NPs to the bedside. In the first 9 months of 2015, over 1,700 patients were evaluated for a BPA alert. It's a lot of patients. In fact, 207 of them had septic shock, and of those, the mortality was 50%. 534 had severe sepsis, and that mortality was 20%. And 906 were determined to have something other than severe sepsis or septic shock, although they may have had SIRS with infection. And their mortality maybe unexpected to some of you in this audience, was 15%. You may remember that in 2001, the slide that Yasmin showed with the continuum of sepsis, that was a 1992 chest slide. When I looked at that data, I was a little surprised because I don't know that even I thought of sepsis that way in 1992. People thought of it that way. But in 2001, Manny Rivers from Henry Ford Hospital in Detroit and his group presented a study that became a landmark study. It became the standard of care for the next decade. It was a small study. It only enrolled 263 patients. And it had a primary outcome of in-hospital mortality. There were two arms to this study. One was called early goal-directed therapy, and that included fluids, pressors, transfusion for anybody who had a crit less than 30, ionotropic agents as per their protocol, and it included central venous monitoring of pressure and oxygen. That was against the other arm, which was usual care. So these were non-study clinicians who took care of patients at the bedside in their usual fashion. At the end of the 3-year study, the results showed that early goal-directed therapy patients in that group had a mortality of 30% versus patients who were taken care of by non-study clinicians in the standard care or the usual care group. All of those patients had greater dysfunction as measured by Apache 2. So based on that study, the Society of Critical Care Medicine and the IHI, the Institute for Healthcare Improvement, promoted the use of these bundles, the early goal-directed therapy bundles. And in fact, this was the standard of care until 2014. We practiced this. We were held accountable for all these elements of the bundle, including we were dinged if we didn't use the central venous pressure and oxygen monitoring. Although imagine small hospitals in rural America being able to do that in their emergency room. I'm not even sure we could do that here in our emergency room. I know where I previously was, we weren't able to do that. So anyway, in a course of about a year, bang, 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 there were 3 major studies. The process study in 2013, which was done in this country, the ARISE study in 2013 that was done in Australia, and the PROMISE study in 2014, which was done in the UK. The process study, by the way, all 3 of these studies had very large groups and enrollments, so that was much different than the Manny Rivers study. This group had 3 arms: early goal-directed therapy, similar to the Rivers study, versus a protocol-based therapy standard study, which used 2 large bore peripheral IVs to be able to get a lot of fluid in, fluid boluses, and then greater than 2 liters, vasopressors, and in this study they also used transfusions as needed for less than 7.5 hematocrit. They measured the lactate to assess for hypoperfusion. And then there was a usual study arm, same as in the Rivers study. The only difference is, keep in mind that these clinicians now had been practicing early goal-directed therapy for a previous 10 years. So it wasn't exactly the same group that the original study had. In any event, this study showed that there was no significant difference in mortality between the early goal-directed therapy group or the standard protocolized therapy or usual care at 60 or 90 days. So they concluded that there was no need for central monitoring, and they reinforced early antibiotics, fluids, and pressors. In the ARISE study, there were 1,200 patients enrolled, and they used 2 arms, early goal-directed therapy and usual care. And again, the ARISE study showed no significant difference in mortality between the goal-directed group and usual care at 90 days. And finally, the PROMISE study, with 1,260 patients enrolled, very similar to the other 2 studies, also showed no difference in mortality between the 2 groups. And in this study, they showed, they really documented how expensive the early goal-directed therapy is using all the central venous monitoring. So based on this, people said, well, usual care, we can just go out and do what we want to do. We don't need protocols, we don't need bundles. But the reality is they were using a bundle. They were using most of the components, 4 out of 6 components of early goal-directed therapy. They were doing early recognition. They were measuring lactate. They were getting antibiotics in quickly, they were putting in enough fluids, and they were using pressors. So no, we still count on protocols and bundles and pathways. And based on those 3 studies, the Society of Critical Care Medicine made an announcement at their 2014 meeting, which is just at this time of the year, to say that they updated the bundles in response to this new evidence, and they said that now that central venous monitoring is now optional. So that's how we've been living for approximately the last 2 years. So, of course, this is a quality conference, so let's talk a little bit about bundles. I'm sure you're all aware of medical evidence-based guidelines, but it's probably not common for you to speak about bundles. So care bundles are a collection of interventions. They're usually 3 to 5, maybe 6, that are evidence-based. And when you perform them all together and reliably, they've been proven to improve patient outcome. A care bundle reduces variation as long as you do all the interventions, you're consistent for all patients, and you do it at all times. We have lots and lots and lots of bundles now. I don't think anybody in this room hasn't come across one of these bundles. And they work. They work for this reason. Care bundles are like clinical guidelines. They're based on evidence. Level 1 is the strongest. Level 3 is the weakest. Level 1 has strong science and good methodology. Based on solid science, they're easy and inexpensive. They need to be well defined. You have to apply the whole bundle. 1 or 2 elements, as we see from the cases and as Trini goes through the literature, it goes through our results, you're going to see that unless you do everything, the patient isn't going to benefit. And the elements of the bundles need to be updated. So we're going to talk about that shortly. So sepsis bundles are considered level 1 based on the literature that I just showed. So this is the Mount Sinai, the current bundle as of September 15th of this year. We initiate lactate. We try to do level within 2 hours to measure the level of hypoperfusion. We expect 2 blood cultures. We expect them done before antibiotics whenever possible. We hope to start our broad spectrum antibiotics within an hour. We hope to give 30 milliliters per kilogram of IV fluid within 2 hours after an initial fluid bolus of about 500 mLs. We really don't care what kind of fluid we give, but normal saline is perfectly fine for that first couple of liters of fluid, and it can be followed by lactated ringers or plasma light, whatever your preference is, because clearly we've got surgery doing one thing, we've got medicine doing something else, and it's all good as long as we water the patients. We have to repeat the lactate. We use vasopressors, hopefully early if necessary, and then we do an assessment again. So I'm going to bring up Trini to talk about our progress and how we're doing.
Hello all. So then for the next section, I will be telling you the story of our Stop Sepsis program that was created by many people here, sitting here, and experiences from all of you here. A bit about the background. So in 2011, there was a call to action in our hospital when our overall sepsis mortality rate was noted to be 33%, which is astronomical compared to the literature recorded to be under 20%. So that same year, the Stop Sepsis program was developed and launched in the emergency department. By the next spring, the program was launched in the 4 medicine units, 2 gen med floors, and 2 hem-onc floors. And then in 2012, many of you probably know that there was an unfortunate case in NYU. There was a patient, a child by the name of Rory Stanton, who came to the hospital with what seems like signs of early sepsis. Unfortunately, he was given fluid and then sent home. He later came back, and unfortunately came back in severe sepsis, septic shock, and died in the hospital. This really got the attention of the Department of Health. It was escalated and got the Department of Health attention. So they came, the state of New York came out with a law called Rory's Law. And that mandates that all hospitals in the state of New York have to have a protocol to manage sepsis to prevent any more Rory stories. And they also mandate that we submit any outcome metrics or outcomes or process metrics and mortality in cases of severe sepsis and septic shock to the Department of Health. So we were, at this point, we were ahead of the curve. And so we were able to expand our program by the end of that year in 2013 to the entire house. And we were able to submit the data to the Department of Health in April of 2014. That was the first time we did that. And as you know, in 2015, the Centers for Medicare and Medicaid, they made sepsis as a core measure, like MI, pneumonia, etc. And this went into effect in October of 2015. So that's just a brief history. So let's talk about our program. Our sepsis pathway, this is our sepsis pathway. It employs a multidisciplinary approach. It starts with the nursing staff obtaining vital signs, these 5 vital signs, and also 3 other screening questions. So vital signs these are the ones that we see on the SIRS criteria: temperature, systolic blood pressure, heart rate, respiratory rate, and saturation. The screening questions are presence of rigor, suspected infection, and mental status. If the patient meets 3 out of these criteria, a stop sepsis best practice alert will be triggered in the EMR. And that would trigger our nurse to communicate with the primary team. The primary team will then assess the patient and determine if the patient has suspected sepsis or not. If there is suspected sepsis, then we follow this protocol to go down and look for systolic blood pressure. If it's less than 90, then the patient is at this point at risk for severe sepsis, and the severe sepsis protocol should be initiated. If the systolic blood pressure is greater than 90, then it's recommended that we obtain a venous lactate. And the venous lactate is greater than 2, then again, this patient at this point is high risk. The patient is at high risk for severe sepsis, and again, the protocol should be initiated. If the lactate is less than 2, then the patient should be cared for and work up as usual. So what is the protocol? This is the 3-hour bundle that comes out to be the 3-hour bundle that Dr. Raucher mentioned earlier. It includes ICU venous panel, blood cultures ×2, antibiotics, and fluid loading. So fluid loading of at least 30 ml per kilogram. So let's say for a 70-kilogram gentleman or person, which is about 154 pounds, that's about 2.1 liters of fluid, bolus, within the 2 hours time frame. And all of this has to be initiated within 1 hour. Lactate should be repeated within 4 hours if it's greater than 2. So, and then for patients who we determined that was not suspected to have sepsis, we should look for other causes that led to the abnormal vital signs that trigger the BPA, right? So all of you in the back, especially in the back, you all know what a BPA is. And many of you have already, are not very happy with the BPA, right? So let's talk about why a BPA matter. Who cares, right? I'm going to try to convince you why it matters. It matters because it's an early warning system. It's a way where we use to systematically identify patients who are at risk for decompensation with a clinical change, is a change in clinical status. And I'm going to show you, based on our data, why this is true. So for the patient who went through this pathway, and even the patient who did not, we didn't think had sepsis, had a mortality rate of 6.7%. This is in comparison to a 1.5% mortality rate in the hospital, general hospital mortality. And for those patients who went on to have severe sepsis or septic shock, they have a mortality rate of about 31%. And patients who went through this pathway right here and deemed not to have severe sepsis or septic shock, they have a mortality rate about close to 16%. So that's why the BPA is an important measure. And it's an early warning system. It's a way for us to identify decompensating patients. It's a way for patients to really call out for help from us. So let's talk about our data, what we have gone through and what we've found thus far. Just very quickly, this is our overall hospital mortality. This is the 1.5 to 2% that I mentioned. There's 4 different time periods, and the averages are subsequently lower. And this is a sepsis mortality that started from 2011 until 2015. Here, this is the average of 33% mortality rate that we had in 2011. We initiated the sepsis program in the ED. The mortality rate, average mortality rate went down to 25%. We launched the program on the 4 medicine units. The average went down to about 21%. Expanded housewide, it went down to about 17% or so. So it's a drastic change. However, we've noticed that the change or the improvement actually leveled off in 2015. The mortality improvement has really slowed in 2015. And in fact, if we looked at severe sepsis and septic shock, the mortality rate has really not changed in 2015. It stayed about 27%. And why is it? We'll talk about it in a little bit. But let's compare ourselves to the rest of other academic centers in the country. Because we always say that we take care of very sick patients. But let's compare ourselves to other very equally sick hospitals with a lot of sick patients as well. So this is the USC data, a United Health Consortium. This is the sepsis mortality ranking. Anybody under this black line is in the first quartile. Anyone above this light line right here is in the worst quartile. Mount Sinai is this blue dotted line. They're here. So currently, we are right here, and we rank 107 out of 135 of all major academic centers. And that is translated to, we have an opportunity to save 35 patients in 1 quarter, so 3 months. But I think we could do better. I really think so. First, we just have to think about why are we stuck? We are really truly stuck right now. We know that now we're going to talk about the adherence of the bundle. We know that at places where people have a lot of, where the adherence of bundle is higher, they have improved mortality. So look at our bundle compliance. This line right here corresponds to the 75th percentile mark for bundle compliance. This is where we are at 58. We want to be on this side for the 3-hour bundle that we just talked about. For the 6-hour bundle, again, we're about 35. We are on this side of the curve. We want to be on this side. So why is our compliance so low? We look at the exclusion for our patients. This is the average New York State exclusion. So these are the patients we decide that the protocol does not fit, and we do something else. So this is the line for New York State. We are up here. So we have higher rates of exclusion from the bundle. And if we look at the number, for the 3-hour bundle, we exclude 15% compared to the state of 7%, and the same numbers for the 6-hour bundle. These are the reasons for why we exclude the patients from bundle. Could be expired within 3 hours, enroll in clinical trial, decline interventions, advance directive. But for us, the majority of our exclusions is because of clinical contraindication. And clinical contraindication in this case for us is usually fluid, or most of the time it's really fluid. Let's look at our fluid exemption. This is all hospital data. Look at our medicine. We have the most of all sepsis cases in the hospital, and we also excluded a lot of patients from the protocol because of fluid. And this is our MICU. How about vasopressors? So this is the data on the vasopressor compliance. This is for average New York State, and this is us. We're about average. We're not any better. We're at 40% average. We don't want to be average. So what have we said so far? We know that the protocol works. We know the pathway works. We saved a lot of patients with this, but we are still not doing very well. Not doing very well with ourselves, but not doing very well compared to other hospitals, comparable hospitals. And we know that likely because when we look at our data, we see that our compliance with the bundle, the recommended bundle, was very low. And we know that we excluded patients from the bundle because of fluid. So now Ken McCardle is going to talk to us about what the implications are for excluding these patients from fluid and the compliance bundles.
Thank you. Good morning. So my name is, excuse me, my name is Ken McCardle. So I lead a team. We manage some of the database registries across the health system. One of our database registries is for severe sepsis and septic shock. You heard about our BPA alert. When that BPA alert goes off in Epic, that actually flags a patient that comes to me, and I build a registry around that. I then monitor, we monitor and follow and track patients throughout the course of that hospitalization. Some of the things that we monitor is we monitor the care adherence to the protocol, to each of the protocols as a bundle, and each individually. So what this is showing is compliance. So this is showing you about 18 months of data. 18 months of data, we have about 1,000 patients that have been diagnosed with severe sepsis or septic shock. The care bundle is there in gray, so you can see patients have to meet each of that criteria. For this period of time, you can see 249 patients met, or just under 25% of our patients met. And then if we look at those patients in terms of their hospital mortality, this is just discharge mortality. Again, this is raw mortality. This is not clinically adjusted mortality, but if we look at raw hospital discharge mortality, we see patients that met our bundle were 15% mortality rate. Patients that did not meet our bundle have 21% mortality rate. If we look individually across our protocols, and again, the same cohort of patients. Right now we're looking at patients that were diagnosed with severe sepsis. Let me also note here that this clinical diagnosis is clinically adjudicated. Our clinical sponsors are reviewing and adjudicating cases on a weekly basis. So this is clinically relevant data and adjudicated with a diagnosis. This is not hospital claims data. This is clinically adjudicated data. For severe sepsis, and again, you can look across individual protocol, and perhaps you can't see significant gaps, but I think you can see appreciable gaps across each of our elements. When we look at septic shock, we see even more appreciable gaps, and in some cases we see some statistical differences. If you look at so during this period of time, we have about 300 patients that were diagnosed with septic shock. Of those 300 patients, you can see we have, for those that met the bundle, just over 30% mortality rate. Those that did not meet, over 50%. So again, across the individual protocols, you can see appreciable differences or some argument for some of what we've obviously seen in the literature, which is early diagnosis and early treatment protocols. If we look specifically at patients, some of the patients that you're familiar with in medicine, during this period of time, we have 207 patients that were diagnosed with severe sepsis. We see about 20% compliance to our bundle. For those patients that were compliant, we see a less than 10% mortality rate for this period of time. Those that did not meet, we see just over 25 or 26% of mortality. Again, raw mortality, these numbers are not, we're not running control groups, we're not running trials here, but I think it is powerful data because we have a clinical adjudication process of making sure we have high quality data and we have actively using this data on a weekly basis. And again, if we apply the same protocol adherence across these Department of Medicine patients, again, you can see some appreciable differences across our chart. So again, we're not running control groups, and there are some caveat to our data here because of patients that are exempted or patients that are not adjusted for other comorbidities. But I think what you can see here is some, again, not just some appreciable differences, but in some cases we see some statistical differences. This is looking at p-value of just amongst our groups. On the left-hand side of this chart, you can see that's a p-value differences between for those patients that were diagnosed with severe sepsis. for that. On the right-hand side, you can see septic shock. And again, just in visually responding to our chart, you can see that there are not only appreciable differences, but I think this will show you that there are some low, if not significant, differences with some of our protocols. Highlighted here are what we're seeing, and again, what seems to mimic literature, which is quick fluid administration. So, thank you.
So now in the last few minutes, we'll talk about the future directions and goals, but we'll bring it back to the case for a moment and really just look at the opportunities that we have as a department to improve the care of these patients. So in the first case, if you remember, it was a 68-year-old female who came in and sepsis was not recognized. She did come in and she did meet SIRS criteria. And so there are two major opportunities for improvement in this case. The first is early recognition. The earlier you recognize sepsis, the better the outcomes are for your patients. The second thing that is important to realize about this case is that the patient did develop severe sepsis and was hypotensive, and it's very important to give those 30 cc's per kilograms of fluid the moment that sepsis is recognized. And she was hypotensive for a long time, but had those fluids been given earlier, she may have done better more quickly. And the second case, I'm sure that many of you might feel like you've taken care of, like you took care of this patient, because we see this patient commonly on the floors. And in this case, there are three opportunities for improvement. The first is the patient came in septic. The first is early administration of antibiotics. Our ID service is available 24/7 and could have given these recommendations over the phone. So there was no need for a delay. The second is source control. The patient came in with purulence from his perm cath site, and we knew that that was a source of infection, and although the patient was stable, he was growing bacteria in his blood, and the perm cath should have been removed. And the third, which is very similar to the first case, is that the right amount of fluids and early administration of fluids would have been critical for this patient. And even though he wasn't dialyzed, he tolerated 4 liters of fluid without any problem, no respiratory distress, and did not require any urgent sessions of dialysis. So please give these fluids early. Oh, and I'm sorry, one last slide. So just in a chart form to recap what I said, the two things that really were not met in the bundle were giving the fluid in a timely fashion.
Okay, approaching the finish line. So, what are our opportunities for improvement? I like to keep things simple. Fluids, fluids, and more fluids. Turn on the faucet, get the blood pressure stable, and measure the lactate and follow it until it normalizes. And if that doesn't work, initiate vasopressors. Follow the bundle, the yellow brick road, follow the bundle. This is Gopi here? Oh, there you are. This is my favorite slide in the world. Gopi made the top part of the slide, I made the bottom part of the slide. The amount of fluid the patients need are equal to 4 venti lattes, or 4 bottles of Fiji water, Poland Springs, whatever your favorite water is. That is not a lot. I give that to my plant almost every Friday before I go home. So patients will not drown. They have nothing in those vessels. They need the water. We're very lucky. We have a new program going on in the Sepsis Initiative and in the Department of Medicine. We were able to obtain 5 handheld ultrasound devices. And so earlier this month, we did a ultrasound workshop, and the leader is Dr. Nelson from the ED. He came, he spent his Saturday morning with us and the hospitalists and the nurse, the sepsis NPs, teaching us how to use the devices. So now we'll be able to go to the bedside and augment the clinicians in terms of being able to evaluate fluid status of the IVC, lungs, and heart. So that's a very exciting program. They're in the process of practicing, learning, getting privileged, and then they'll be able to go out and help with recognition and management using these devices. So what are the take-home messages for today? Clearly, sepsis carries a high morbidity and mortality, but there's an opportunity for us to bring those numbers way down. The best practice alerts are an early warning system. It means your patient's in trouble, whether it's sepsis or something else. Pay attention. Patient is basically, got something written on his forehead and said, I'm in trouble. And so time is of the essence, and your evaluation really counts. Administer early and appropriate fluids, and that will save lives. I love this quote from Einstein because this is the way I think, very simply, and I hope that that's how we've approached this conference today, leaving you with just some very simple to-dos. But hot off the press, this slide wasn't here, yesterday when we practiced this, but it developed last night. I got no less than a dozen emails from people last night who are at the Society for Critical Care Medicine conference as we speak. And last night, they announced that they're developing new definitions and assessments for clinical sepsis, septic shock. There's no more severe sepsis. I never really understood that anyway. There was always sepsis and there was septic shock, at least in my world. So severe sepsis is no longer going to be a term used to define sepsis. Unfortunately, we can't make it go away today or tomorrow because we're still measuring it because of New York State and because of CMS. But ultimately, at whatever turtle speed that they get along, they'll manage to change that. So there's a lot of great literature, that papers that actually were announced that I think are free of charge on the internet right now. Some people sent them to me, I'm willing to share, that really say we're in a whole new world for sepsis now. And it seems like every couple of years they do an update. So I'd like to thank my collaborators for doing a wonderful job and giving a great talk. I really enjoyed working with them over the last few weeks to prepare this. I'd like to thank the members of the sepsis leadership team, the steering committee, and all the sepsis champions. The work that Ken presented is really done on the back of many, many nurses and doctors who review cases and work very hard to allow us to have a terrific sepsis data registry. So with that, we'll take any questions for any of the speakers. Andy?
That was terrific. I completely agree that the focus has to be on early recognition and fluids and source control. What about the impact of ICU beds, in terms of getting patients intense monitoring and vasopressors more promptly here at Mount Sinai?
I think that it's a struggle. I mean, I'm not going to diminish that in any way. However, the alternative is the high mortality rate. And I have the promise from Dr. Powell and Dr. Rowe and the critical care people sitting in the room here, they will help us. If we put somebody into pulmonary edema, they will help us get them out. But the alternative is not tenable. So we just have to deal. We have to do it. They will make a bed if they can. If not, they'll stand at the bedside with us. The Mars team is there 24/7. And in the summer, we're hoping to have a rapid response team as well. So we always have to do the right thing for the patient, and we'll worry about the resources later.
Yeah, about 20 years ago, the concept of a nursing home acquired infection crept into the literature, and now I believe that they call it healthcare acquired or whatever. So if you back up, how many of these patients came from nursing homes? How many were very old people who could have been monitored by some mechanism earlier and picked up with a pre-sepsis diagnosis in the location that they were and treated for that, rather than not being diagnosed and not being treated in that arena and ending up in the ED and getting into your protocols. So I'm trying to back you up out of the hospital.
Right. I don't know that I know that number. Ken, do we know that number?
Yeah. So that sepsis present admission about 70%.
Trini, stand up.
We currently do not have the data, 70% present on admission right now of sepsis. We are currently collecting data on looking at the data, which of these patients actually came from nursing home, and very soon we'll have that data as well.
Or from the home care program.
Right.
I mean,
Yeah.
Trini, why don't you just use this as a very quick opportunity to talk about our palliative care initiative?
Oh, sure. Yeah, thank you. So this is a hospital initiative where we know that we're doing the best we can for these patients, fluid, antibiotics, and everything else. But there's also a group of patients that we think that could benefit from other interventions as well, specifically palliation. So this is a protocol that was developed with Dr. Emily Chai and the rest of the sepsis team. Patient will be screened based on this PALCare score, and if they meet the score of 3, palliative care is recommended. And if those meeting 4 or higher, our sepsis NPs will communicate with the team and will make the call to the PALCare consultation, because these patients have already high mortality rate, and also, as we know, if we look at just the chronic disease process alone, we could already argue that these patients should have outpatient palliative care consultation already.
So I think that sort of is part of your question. These patients, many of them really should not be coming back to the hospital. They should be being treated in place, and all the multiple revolving door readmissions, we're not making them any better from their underlying chronic disease.
Beth?
Yeah.
I actually have a question, kind of related to this discussion, but has a different side to it. Do we have any evidence that shows the evidence of sepsis is different in older adults? So are we missing the older adults who come in with sepsis, but they don't really necessarily, do that, alert us with that BPA because they don't satisfy 2 or 3, criteria that we have? And are those the people who are being missed and,
Right.
basically at the end they will add to increase mortality in our hospital?
Yeah.
And what are the ways to kind of prevent that or satisfy that?
Sure, I could take a stab at it. I think that we know that I think the recent article, I think in 2015, came out that the SIRS criteria actually does not, SIRS criteria, they don't identify about 8%, miss about 8% of all sepsis. And I think it leads to your question. And for our BPA, for our best practice alert, not only take into account of the BPA, but we also take into account of the other questions, presence of rigor, automental status, which is usually the presentation of elderly patients. So we are taking into account of that as well. But certainly we could do a lot better.
If you look, Mount Sinai Queens is also part of this database. We didn't present their data. They have a much older population there, and they've been working hard to address their bundle, but doing it even sooner and faster than we are because of the geriatric population. And they've done very well with their mortality statistics. They've got even earlier recognition. They use their fluids, and they even go to pressors faster, and their mortality rate is better than ours is.
Yeah,
So,
I think that might be the direction that
exactly. The elderly are
identifying
different.
this data, the data that was presented based on age, to
Right.
see who is the one that's doing worse. And I think
Well, Ken is working with our biostatistics department to really do some more slicing and dicing of our data, and we hope to come back to present that to you. I think Dr. Murphy?
Yeah, just looking from the perspective of an ESRD patient on dialysis, if you combine that with any one of your other criteria, advanced COPD, which a lot of the ESRD patients have, maybe stroke, cardiac disease, I mean, pretty quick, most of our ESRD patients will actually be triggering a PALCare consult.
Yeah, so based on this, you cannot meet the criteria unless you have one of these. One of these.
So it has to be a combination.
Combination of these
but
two.
But still, you're going to have a significant number.
So we do have data. Right. No, actually, we have this data based on, we developed this based on the literature we have on palliative care, and with also the palliative care team here as well. These are the criteria that other places and other, I guess, a screening tool have used in the past. And then we are just adapting it to our patient. In fact, we are making it even more stringent than their criteria. So in order to meet this, we have to have both of these. And in fact, if we did it, we look at our data of the last 4 months, we only have 50 patients. Yeah. And only maybe less than 5 patients qualify as automated consults.
We'll stay as long as you will.
So with regard regards to the use of vasopressors, I think there's a lot of differences in style of when people are initiating that, whether they're waiting for people to no longer be fluid responsive versus a certain amount of fluid they'll give before they'll consider it. Is there evidence about when you should be using vasopressors?
I think that at the point where, you just think that either you've already used too much fluids and the patient, there's going to be, the patient is not going to benefit anymore because it's the only way to keep the blood pressure up. You can use fluids and vasopressors together. I think this is where the science and the art of taking care of patients comes in. But what we don't want to do is have patients who have profound hypotension or even hypotension for prolonged periods of time, because that is damaging to all of their end organs. So in my experience, in my practice, it was always sooner than later. Eric?
Similar question is the choice of vasopressor, particularly in the setting of limited ICU beds. What should we use, when, and where?
I'm sorry, what was?
I
saw Dr. Murphy.
When and where?
Yeah, and so what vasopressor in the setting of limited ICU beds, what vasopressor should be started empirically up front as the first choice?
So I think that Levophed has been what's been studied and it's what's best to use in sepsis. I think that that's very difficult. You can't use it on the general medicine floors. But as Dr. Murphy said, I think that we need to do what's best for the patients. Excuse me, Dr. Raucher said we need to do what's best for the patients. What's best for the patients first, and then worry about the resources later.
Right, and again, Lisa, Dr. Powell, if you want to comment on that. Patient-centered care. Let's just always do what's right for the patient, and we are available to work with you to help, to hold your hand, to get you through it. We'll do that. All right. I think anyone else who has questions, please come up, and thanks for coming.